the three other speakers. First of all, Leslie Hill, who has a BA in social work from the McGill University. She has a master's in managing and development organization. Her professional experience had her work with different populations, children, mental health users, and people with addictions. She had different functions of managing in terms of social health in Mauricie, Montérégie, Montréal, and she has retired since 2022. Leslie Hill is very much committed towards different social causes, people living in vulnerability context, and she believes in prevention and the importance of tackling inequality by actually integrating those people who need these services, those people who need to be included. Now, we also have Marie-Claire Rufagari. She is a coordinator and she also works with refugees and immigrant people, and then she has taught for 3 years modèle d'intervention et relations interethniques, and she's member of the Committee on Diversity from the south of Montreal. And then we have Dr. Geneviève Auclair, who is a family physician in Inuktitut Health Center in Nunavik. She has been there for 2007. And she has a unique work place and working conditions. She practices medicine in the Nordic context, and she works in the regional department of medicine of Nunavik, and she also is an activist so that the rights of the Nordic people in terms of healthcare access be more recognized. So we're really happy to have you three here, and for the next 20 minutes I have 2 questions to ask you. So you're going to have 3-4 minutes each to answer, maybe even more, 3 minutes than 4. My first question is, according to you, who does not benefit from healthcare in our society right now? If you have examples to teach us, to bring us, we would like you to do so in this respect. Madame Goularégui, I would start with you. Thank you very much for having me. And I've just heard it was very interesting what has been said. I would like to tell you about immigrants, refugee people, or those who don't have a status, because this is a population that just comes because our society has immigration policies. Today we have a lack of workers, so we have a strategy to bring immigrants to the regions. So those immigrants who come, they have a lot of challenges, and these people come with different statuses, with different profiles, with different experiences. So this means that in terms of reference in our society, this is going to be a challenge. What preparation can we give them, and for also those who are going to deal with them and meet them? So I would say that already as a start, we have to see who came on a permanent basis, those who come with status that, for example, they came because they left because of violence. We will have refugees with different statuses, and then we also have a temporary immigration, and we can see that more and more. I can tell you that from those workers that come in different regions of Quebec, well, they have temporary status, and it's very important to see that when you come to Quebec, and you have a permanent status, or when you have a temporary status, or by being even just waiting for a status, it's going to be unequal already. So as a start, it's not all the newcomers that are going to benefit and access to all the same type of care and to all the same rights. So I would say that just very quickly that one of the lawyers said it very well. But we are a society of right, but we need to fight more and more for these same rights. So it's important to have resources and access of these access to the services. It's very important, and it is at stake for all these new people. I'm going to give you now a recent example. A young refugee woman who came. She has come a few years ago. We talked about mental health earlier, and she, in order to be able to access healthcare, it was such a hard situation for her, and she had suicidal ideas. So that's why I found it interesting to think about. We have to bring our healthcare towards the population, especially the most vulnerable people. I heard earlier that among this population who don't consult, don't go and see a doctor, but I would like to ask the question the other way around. Do they have the conditions to consult a doctor? Do they have the conditions to participate? We can see more and more professionals, and obviously I had the pleasure to meet many professionals, healthcare professionals and employment and education professionals in Quebec, and I think that earlier the systemic question came up and structural question came up. Even though we've had immigration for several years, our resources work as if it was not the case. So the challenges are not going to be only a challenge for these newcomers, but it's going to be a challenge also for our healthcare professionals. So I think that it's important to take all these new realities into account, whether it be in terms of status, profile, experience, because if it's not the case, it will mean that our interventions, our diagnosis, the doctor's diagnosis, are going to lack some parameters, and when we lack some parameters, you can imagine how the intervention is going to also be affected. And I think that the challenge of these people is replicated in the challenges of the healthcare professionals, and I think that a lot of adaptations should be done, and we should also even document this.
Yes, so it's really linked to the context. Yes, the context, lived experience, and adaptation of practices. And unfortunately, this happens in many areas. So imagine if people who are born and living here, citizens, meet those challenges. Imagine what newcomers experience. I give you an example. Oh, I'm very sorry. Maybe we'll get back to it a bit later, but we will let the others participate too. What about you, Dr. Auclair, regarding northern populations and indigenous populations? So first of all, can you show my first slide? I talk as a non-Indigenous care provider. I don't talk on behalf of them, but I talk beside those patients I met. This is an example of cultural diversity. We have 11 recognized Indigenous nations in Quebec. They have their own cultural background in their 55 communities, so there are certainly 55 realities, different realities and different dynamics. I work in Nunavik. This should not be this is different from the Nunavut and the north of Quebec. Nunavik is the size of Spain. However, there are 14 villages that are not linked with roads or train, or you can only access those villages with a plane. Next slide. So here you see what a medicalized transportation looks like. So every people who needs to go to the hospital or emergency, they have to take one of those planes in order to go to the closest hospital. Generally, it is located 200 kilometers away from their home. And if the weather allows it, the plane can access the village easier. So this is very common. If somebody has chest pain, for example, they have to take that plane. Tuberculosis is also a plague of our area, and there is no way to do a scan in the area. So if somebody is suspected to have tuberculosis or needs a chest scan, they need to take one of those planes to go to the hospital. And so here we see a geographical barrier to care. And so the AVAC, this airplane is not pressurized, so it's emotionally heavy for the people transported. So we don't have CT scans in our area in Nunavik. So when people need to go to intensive care, we send them to Montreal. Why not to a closest location? Because in Verdun and Chigamouk, they do not have all services either. So we would need liaison nurses and interpreters. So that's why we send them directly to Montreal. So there are linguistic obstacles too. As you have seen, there are 11 indigenous nations. I am more experienced with the Nunavik, and Nunavik care providers are mostly French-speaking providers. So it's the second language of most patients and care providers. Some patients speak French, but it is their third language. So imagine to always see a family doctor and have to speak your second or third language. So for sure there is a lack of specificities, there might be some information lost. And then the Commission Vient, which studied the relationships between public institutions and indigenous populations, showed that those nations had no access to interpreters. And since the recommendations that have been made by the Commission, not much has been changed. There are many indigenous nations who are labeled as being English-speaking nations because it's their second language after their traditional language. Above the language, there are also all the issues linked to discrimination, not being welcomed in your own culture. Having a nurse practitioner or a family doctor doesn't mean that you feel welcomed. And so there are different concepts to keep in mind. I don't know if you saw the video about Joyce Echequan. So you can be in a hospital and be very badly received. In Nunavik, given the fact that care providers do not come from the territory, there are gaps and there's a huge turnover. So nurses, there's a turnover every 18 months, for example, for nurses, and doctors, there's also a turnover amongst doctors. So this is an issue for continuity of care. And then regarding digital healthcare, this does not exist in Nunavik. We also do not have a point of care on site with lab tests. So there are many obstacles for the population I take care of in isolated territories, and particularly on indigenous land. There are lots of barriers. And I'm not even talking here about historical obstacles and colonialism, because we could talk about that for 400 years. Thank you very much, Dr. Auclair. There are indeed barriers for patients and for care providers. These are, as Madame Miss Rufagari said earlier too. So to you now, Miss Hill, according to you, who is currently underserved in our system of care? Do you have any stories or example? Thank you very much for your invitation. I will insist on the social dimension of care. Dr. Leblanc was talking about health health determinants, and we have to think about those vulnerable patients and about other factors like poverty, isolation, social problems, domestic violence, intrafamiliar violence, homelessness, mental health, addiction, and people living with handicaps, and we could go even further on that list. There are many groups in our population who have no equal chances to access mental health services and medical services. So I want to insist on this social dimension because people go through trauma throughout their life, and they have a lot of stigma. They face a lot of stigma in society, and stigmas and stereotypes like, oh, this person does not want to get organized, these people don't come to appointments. And as I mentioned, but as Dr. Breton mentioned, even if we had enough doctors, and even if the Quebec Family Doctor Finder or primary care access point worked perfectly well, those people might not look for that for those services because they do not trust society, the services are not adapted to their needs, and sometimes they're ashamed asking for help. So we need to remove those social barriers and the individual barriers that people impose themselves. And if we think about a new health system, we need to think about how to remove systemic barriers, so like the geographical barrier, the linguistic barrier. So even people who are not vulnerable, who, for example, are English speaking, and if they get out of the Great Montreal area, and unless it's hard to access services in English. So imagine people who speak another language and they need the interpreters in order to mitigate those gaps. So we need to keep that in mind when we try to rethink a primary care model that works. We will talk about different models a bit later, but I could give you a little teaser right now. We need to meet people. We need to go towards those patients who are afraid of our services, who will not come towards us. So we need to have new models to go within communities to meet those patients with different paradigms. And I will elaborate later. Yes, indeed, that concept of going towards people and meet them where they are is something that you all mentioned. In your work context, did you come across models that worked or that could work in order to better reach those patients and to better answer the needs? Ms. Rufagari? So what's interesting is when people, the patients, are also engaged and when they are consulted. When I arrived in Quebec in 1994, I was working in a network to help people that were victims of organized violence. And there were doctors, psychiatrists, social workers, lawyers, and community workers who met, and they wondered if their intervention could help. They realized that in silo, when they were isolated, they did not know the reality of those patients. As Dr. Auclair mentioned, yes, there is the question of language, but also of communication and interaction. And quickly they realized that they had to create a network in order to have a multidisciplinary team. And this also happened in Saint-Hyacinthe. I can give you the documentation. So those initiatives do not last long because of the lack of financing and acknowledgement. So here refugees who were taken care of by the government, um, who had rights, but they were not very well educated, and these were challenges. So training was provided in multidisciplinarity. So how do we break silos? People have to communicate together in order to act together. And so there have been new realities, and it is important to see how those new realities were integrated in our policies and practices. So all those people met, and they noticed that without willing it, they all had a negative impact on those populations. And so every single one of them on their own was failing their mandate. So the trust that is established in those multidisciplinary teams allow for continuity. So when those professionals are working in silos, this increases the gaps. A woman, a refugee who saw different professionals asked us, to how many people will I repeat my story and say the same thing before I'm understood? Because all those professionals were not in contact with each other. So we need the right conditions and the right settings. If there is no link and trust established at the beginning, everything becomes difficult. And so this is a challenge for the whole population, but even more for the refugees and vulnerable population. So no matter the context, it is important to have teamwork amongst professionals, right? Yes. And also teamwork with community workers. We see those people who do not reach out to institutions. We have 160 institutions that work with newcomers, and in Montreal too. So those people, we need to collaborate with them. And this is what happened in Saint-Hyacinthe. This initiative was led by a community organizer. So that was a very nice collaboration. Yes, and the doctor who talked about it, why don't we go back to the model of local community service centers? Thank you, Ms. Rufagari. Dr. Auclair, what about you? Did you witness any solutions? Yes, so there are solutions at different levels. So please show my slides. Dr. Leblanc talked about the health determinants. I talked about the different indigenous nations. And now I will give you different examples. This is the concept of health according to the Inuit population. The Inuit population of Nunavik, the link with the territory is omnipresent. And the whole relational aspect of family, community is very important for health. And so So health goes beyond the walls of the clinic. The territory is also very important for the Inuit nation, but also for other indigenous nations. Next slide. So this is another diagram that shows the determinants of health for the whole population. In Canada, in the Constitution, we recognize three groups. The First Nations, which were grouped the 10 other First Nations. Then we also have the Inuit and the Métis. This is a nation recognized in the west of Canada, and the Inuit is another group. So we have those three groups, and this algorithm shows all three groups. Colonialism is a very important aspect to keep in mind, and that has the most impacts on the infrastructures and the community, and on also all the other local determinants, like job, food security, etc. So those health determinants are different according to the population. So it's not a one size fits all. It will always be more expensive in the regions. You remember, you have to take the plane. And so the plane to go in those northern communities, it's $600. So it's just to give you an overview of the costs. And then self-determination of those nations. Some want to, are governing their own health care services, like in Nunavik. However, as Dr. Leblanc said, all structures, even outside Nunavik, have to follow the path. And other sectors have also to be improved, like education, in order to improve all the other aspects, like social workers, nurses, etc. It is important to give decent salaries to social workers and to interpreters too, for example, because interpreters are very needed for that network, and if they're not adequately paid, we can lose those key stakeholders. One of the most beautiful example we have is the midwife training program in Nunavik. Since 1980, the profession was not recognized in the area. And so some hospital recruited abroad and outside of Quebec because they were not recognized in Quebec. So now we have approximately 15 Inuit midwives who can welcome women throughout their pregnancy. And this is the most beautiful cultural example we have in our system. And we would like the same thing to happen with other professions. We talked about interdisciplinarity. I mentioned it very briefly. We do not have family doctors in all 14 communities. We have nurses who have broader roles, and they are amazing. However, we also experience a labor shortage, and we think that this model could also work somewhat else. Our doctors and our nurses have broader roles. I'm very sorry, we only have a few minutes left, and I want Ms. Hill to speak to. So on the individual level, we need to recognize our bias and have a self-reflection that is constant regarding all communities. Okay, so we need to rethink the whole ecosystem of care. Ms. Hill, do you have special examples in mind that could be useful? So the models that work are the models that take into account the lives of people and that are flexible enough to adapt to their realities. So when we talk about participants, what helped them the most, it's always the relationship that they established with a professional. And this opens the door to a patient telling to a friend or a family member, I know someone who could help you. In this way, we can help marginalized communities and people who are scared of our services. We talk about relational continuity. However, before having that continuity, we need to first establish that relationship. So the patients need to feel safe. And then how we welcome patients is also important. Here, it's not the professional act, it's the first contact you may have with a system and how people feel, what's the experience, and that will open the door to to the solutions. I will cite a few models. The first model, I had a presentation yesterday. It's the model in which the work is alternative and paid per day. And people might think, what does that have to do with health? Because here the outcome is general health of homeless youth. There were too many young homeless people, and they were gathering and putting themselves in dangerous situations. So that institution, Tapage, decided to develop a program that allowed those young people to go to that institution and get some money for the day in exchange of services. For example, helping elderly people to go to their medical appointment, or clean a street, or get rid of the snow in a street. So people go there initially for the money, for sure. But then little by little, they establish a relationship. For example, if they have a mental health issue, somebody tells them, I know someone who could help you, or a social worker or a psychologist, and they can encourage them to get back to work. It is an integrated model in a non-threatening context. Now I will go back to standard health. A social pediatry, Dr. Julien, and the clinics who, for example, do music and arts with those children, and they have cater to those family needs. They welcome those families and have a meal with them. The parents can come with their children. And we can integrate different medical services within that framework. In Quebec, there's also another initiative for mental health that once again, in communities, instead of asking for those young people to go to those different institutions and knock at each door, those services go to the communities and to those young people. So I work mostly with young people, but we also have other patients. We have to think about home services for people who have reduced mobility, and we need to bring those services to those people and see how we can add interdisciplinarity in the mix. So I think that the solutions are always the same. Go towards those patients. Dr. Leblanc was talking about the reaching out, the outreach method. So that's what we have to do. The people who are the most ill are the people who cannot reach our services. So we do not only need interdisciplinarity, we also need intersectionality, because everyone has a role to play. The city hall, the education, etc. I could talk about this for an hour. Yes, I would love to give you hours and hours to each one of you, because there's so much to say. However, I would like to keep some time for the Q&A at 2:15. I will now invite those who would like to stay a bit longer to stay here till 2:20, or at 2:15 you might take your break. But we could leave 20 minutes for the Q&A until 2:20, and those who need to leave at 2:15, go ahead. So again, you can raise your hand using the reaction button, or you can write your question in the chat. I know that a lot has been said. Maybe you're a bit tired, you want your break, and that's all right. I see a question in the chat box. I'm going to read it. Martin is asking, how can we earn trust from a victim of sexual assault or domestic violence, and who has been discriminated in the past by the system. Maybe you could answer, Dr. Leblanc, you can answer too.
I can answer this. So someone must listen to that person instead of imposing the services. It's not bad what we do, but sometimes we tell them, well, this is what we can give you as a service, but we should rather ask them, what do you need? And taking into account their stories. This takes time. Maybe the person is going to tell them also their story in the wrong professional, quote unquote. So we have to accept the fact that, okay, people sometimes don't feel that they're being listened to, and they can feel violence when they're expecting understanding. And this time should be taken. It's very precious. And obviously, time is what we have the least of in the services that we offer. There is a saying in English that says, nothing about us without us. So it means that actually everything that you say remind me of this saying, actually.